Hi, everyone. I am Autumn Lentz, the Education Manager at the Foundation. I want to say thank you for joining us today with our Answers from the Experts Q&A. We are very excited to have you here. So before we get started and I introduce our panelists, I do want to go over some housekeeping. As I said, I'm Autumn Lentz, the Education Manager here at the Foundation. We are here for Q&A. That's why you've joined us. So please use the Q&A tool in Zoom to enter your questions, and we will try to get everyone's questions answered. We will be recording this program, and we will be making it available on our YouTube channel within, sometimes we get it up the next day, sometimes it'll take a couple of days. So we want to say thank you to our individual donors and our corporate sponsors. Without donations and sponsorships, we wouldn't be able to bring these wonderful programs to you. One last thing before we talk more about our speakers is that upon conclusion of the webinar, there will be a survey that pops up. We'd really appreciate you completing that survey. It is how we know if we are meeting your needs and we make adjustments to what we are doing. So today we have Dr. Ghione and Dr. Geller, who are both from Memorial Sloan Kettering Cancer Center in New York. Dr. Ghione is a hematologist oncologist who specializes in the treatments of lymphoma. She has worked in lymphoma patient care and research for more than a decade and believes the pace of improvement has been incredible. And we love hearing that because we're always looking for improvements to treatments and new treatments. Dr. Geller is a dermatologist who specializes in caring for patients with cutaneous lymphoma. He has expertise in the diagnosis and treatment of basal cell carcinoma, squamous cell carcinoma, and early stage melanoma, as well as other rare forms of skin cancer. So if we could please welcome Dr. Geller and Dr. Ghione. Hello.
Hi, Autumn. Great to be here today.
Glad that you can join us.
I'm very excited to join us today.
And we are all very excited to have you. So before we start with our first question, one thing that we do like to mention is Dr. Geller and Dr. Ghione are here giving their opinions based on patients that they themselves have treated. So please do not take anything they say as a second opinion. You should always discuss all treatments with your treating physician. So please keep that in mind as they're answering questions. So let's go ahead and just dive in on our first question. Can you develop multiple mycosis fungoides like classic MF and FMF? If yes, how is it treated? Who would like to jump in on that one first?
Yeah, I can take this question. So as it's mentioned in the question, so we know that mycosis fungoides is a very heterogeneous disease regarding the presentation. And we can have like different lesions look differently in different age groups and also in different, ethnicities and races. And also in the same patient, we can have different lesions. Sometimes they look very, very typical, meaning that it's like psoriasis or eczema appearing lesions, red patches, red plaques with some scales on top. But sometimes we get to see the more rare, variants of mycosis fungoides, meaning areas that are more like papular, areas that look like acne, areas that are, we can have like hair loss over them. And this is sometimes can be a mixture in the same patient. Sometimes that is making our, diagnosis more difficult, but it's definitely something that we tend to see. We can see that also in patients who have both hypopigmentation and hyperpigmentation in the same patient. So usually in these cases, eventually the diagnosis is based on biopsies, but many times we need to, to keep our mind open once we have a patient who has mycosis fungoides, that also lesions that look different from the lesions that we're used to see in these specific patients might be still the same disease or progression of his disease.
Yeah, exactly what I wanted to also add is that sometimes when the lesions change or start changing, that's a sign where we would like to look a little further into that and see if, for example, the mycosis fungoides is progressing to a slightly more aggressive disease or something like that. And that's why the same patient can have different types of lesions at the same time or progressively in time.
Great, thank you both for that. It was very good information. Our next question, when should a mycosis fungoides patient see an oncologist?
Well, it's very hard for me to tell exactly the point at which you should also see an oncologist, because the way we work here at MSK is that we basically see the patients together from the get-go. And but I would say whenever a patient feels like their dermatologist is starting to think that there's a need for a treatment other than just skin directed, then that's where probably the dermatologist starts having a role where they want to include a hematologist as well. But I think it would be good to see a hematologist anyways from the get-go, and then they will decide the pace at which they want to see you. Maybe it can be that you see the dermatologist more often than the hematologist, and the hematologist can see you just once a year or every 2 years, something like that.
Yeah, I can also add to that. There are different approaches. I mean, looking at different, institutions, and I totally agree that at MSK we go for one attitude, which says that usually the patients get to see both of us in our coordinated clinic. But there are some places that the patients get to see the oncologist only when they have involvement of their blood component, that they have disease in their blood. In some cases, it's only when they need chemotherapy, or only when they need a hematopoietic stem cell transplant. So it depends on the expertise of the caregiving physician. Some dermatologists have a lot of experience also prescribing and giving the oncological treatments, chemotherapy, and the immunotherapies that are given today. So it changes from one place to the other. But I think that most important is that the patient, like Dr. Ghione started saying, the patients needs to feel comfortable in the treatment he's getting. It's never wrong to go to get and to hear also the other, discipline, if he's treated by an oncologist, to see what the dermatologist who is treating cutaneous lymphoma has to say, and vice versa. I think that working together is very important.
All right, thank you so much. And I'd like to apologize if you guys are hearing the thunder that's coming across my microphone. We're having some pretty heavy storms here in Michigan right now. So our next is a two-part question. We always get some kind of questions on UVB. So we have, how many exposures or how much exposure to NB UVB is a risk to cancer of the skin? And also, is it a forever treatment that you have to take when you have mycosis fungoides?
So phototherapy is a very well-established and a treatment for mycosis fungoides, and it's one of the treatments that's actually we've been using for many decades now, and we have a lot of experience with that. It's also a treatment that is given for non-cutaneous lymphoma, conditions like psoriasis, eczema, and it's considered as one of the skin-directed therapies, and it's very, very safe, meaning that we can give it to children, we can give it to pregnant women, and the adverse effects are minimal. Usually it's you can get burned by phototherapy, or you can get erythema or irritation by the UV exposure, but actual skin cancer by exposure to narrowband UVB are very, very rare. And we know that the only cases that are described, or the cases that are described, are mainly involving genital areas in men. Because of that, we cover these areas during treatment. And of course, we cover the eyes due to prevention of cataracts and other eye adverse effects, like ophthalmic adverse effects. But there is no cutoff of when should we stop giving light therapy. There are some patients that respond very well to light therapy, narrowband UVB, and in these cases we know that we can give them maintenance treatment, meaning like a treatment once a week or once every 10 days even, and this can keep them like clear and without any flare-ups for long years. We do try to taper off and to take patients off light therapy because, you know, we cannot keep them forever on light therapy. But I do know that there are some physicians and some patients that do stay on this treatment for many years. And as long as they are, you know, followed by a dermatologist, looking both at their skin for other skin cancers, it is a good possibility for keeping patients like clear.
All right, thank you very much. It was a very good answer. Our next question is on mycosis fungoides. Is there a need for a mycosis fungoides patient to have their blood checked? And if so, how often? So in patients that you are seeing, how often are you asking for blood work?
So it really depends on the stage and how the mycosis fungoides is going. I think I do tend to check every patient that has more than just a minimal stage of mycosis fungoides for blood involvement, and that's more of a fancy blood work called flow cytometry. But I do also, even if they have very small involvement, I do want to check labs every year at least to have an idea how their bone marrow is working and if everything is going well, and especially if they are on treatment. There are some treatments like targretine, bexarotene, where you need to check thyroid and lipid panel very frequently to see if there are any side effects. And every time I suspect that the mycosis fungoides might be getting a little more aggressive, like doing nodes or going into the lymph nodes, then I certainly want to check the blood work for these fancy flow cytometry to look at minimal amounts of lymphoma that might be there.
All right, thank you so much. We have our next question is, we don't see a lot of pediatric patients, but we are starting to see a few more, is what type of doctor should treat my 6-year-old who was just diagnosed with mycosis fungoides?
So for pediatric population, I mean, there are like pediatric dermatologists who have experience in cutaneous lymphoma, but also all cutaneous lymphoma experts, they also treat like pediatric populations. So either a pediatric dermatologist, again, if we're talking about a case of early stage, if it's like advanced stage, so also the oncologist and hemato-oncologists should be involved. But in like very early stages, it usually starts with a pediatric dermatologist. And if he needs more experience, he can consult or refer to a cutaneous lymphoma dermatologist for a further assessment and treatment.
Okay, thank you so much.
Yeah, I would say same thing for the oncologist.
I'm sorry, could you repeat that? I talked over you by mistake.
No, I would say exactly same thing for the oncologist. There are lymphoma doctors that are pediatric oncologists, and I would start there and then see if there's a need for consulting with someone that does more, cutaneous lymphoma only. But yeah, same principle.
Okay, thank you so much. All right, our next question is on Sezary. When someone has had success with a treatment for Sezary syndrome and takes a break because their levels are low, when they return for treatments, must they start a new treatment? And this is a question that's a live question, so we might need a clarification. When you say new treatment, do you mean a new type of treatment or start over back at the first level that the treatment was? So if the doctors aren't able to answer your question clearly, if you could add a little clarification on that in the Q&A. So who wants to tackle that one?
Well, so yeah, theoretically, if he was responding, he or she, to the last treatment, and it was well tolerated. And the break is just because you know, the treatment was going so well. Then I think why not continuing again with the same treatment. Now there are some therapies that can be done only for a certain time, because maybe you develop side effects or things like that, where you don't really want to start again with the same thing. But it's not, you know, it's not written anywhere that you can just start again with the same treatment you were on before if it was working and you didn't have so many side effects.
So she did add some clarification. It was new type, and specifically I always say this wrong, romidepsin.
Romidepsin.
Romidepsin, thank you. There's always one word I
Sure.
can't get in every one of these, so hopefully that's the one I can't get this time.
Yeah, romidepsin is sometimes a very good drug for Sezary, and I think it's one of those that if you tolerated it well, really you can just start again and do it. And sometimes, you know, the schedule of the romidepsin is 4 hours once a week for 3 weeks. So that can be a little daunting, and I totally understand that one might want to take a break. Sometimes if you're doing really well, what you can do is just go every other week or reduce a little bit the intensity. The problem of it is that sometimes people really have side effects after they get it. So it really depends case by case. But if you liked it and if you were responding to it, that's not the medicine that has a cumulative side effects.
Okay, thank you. And our next question is, how often should a patient with mycosis fungoides have a PET or CT scan and or a biopsy?
So I can approach the biopsy issue, and maybe Dr. Ghione will respond to the PET scan. So biopsy, and we are, I think, also refer to that in one of the first questions. So usually the recommendation is to repeat a biopsy when there is a change in the rash. I mean, if there is a diagnostic biopsy, meaning that the biopsy was reviewed by a pathologist who, well experienced with diagnosing cutaneous lymphoma, and he decided that it meets the criteria, then we don't need another biopsy if the same, rash stays for long. But if there is some change in the rash, like new lesions appear that are different from the lesions that were biopsied before, or new lesions that appear after the patient has been on a drug that cleared completely the skin, if there is some sort of a change of what was used to be seen in that specific patient, then we usually repeat the biopsy. And the idea is to see whether the cells changed. We can also look at specific markers, and some of them have meaning regarding the treatment that the patient can get. We know nowadays we have some immunotherapies that target specific proteins that are on the outer membrane of the cells, and if we show that we have them, we can offer this treatment for the patient. So this has like a huge importance. Of course, that in patients that we don't have a diagnostic biopsy, sometimes we need to repeat biopsies until we get to the exact diagnosis to see whether it is a true lymphoma or something that just mimics lymphoma. And we know that some of the patients, it's very frustrating because they go through like many biopsies until they get the diagnosis. And sometimes still after 8-10 biopsies, it's still unclear. And sometimes this uncertainty is very, troubling to some of the patients and sometimes also for the physicians.
Yeah, and
Mike, can you
regarding the PET scan, oh, sorry. There's no rule for the PET scan. What I used to do is, unless the patient has a very limited stage disease, like really just one patch or something that really doesn't make me think of a systemic involvement, If it's just a little bit more than that, I do a PET scan at the beginning, and I look for, lymph nodes or systemic involvement in the body. If there are lymph nodes that are very active, then I try to do a biopsy of those and see if there are cells of the mycosis fungoides in there, and if they are there, if they're really growing in there, or it seems like they're just passing by through the blood, because that's very different. In general, if the patient stays stable and doesn't really evolve, and the mycosis fungoides is always stable and well controlled by the disease, by the treatment, I don't repeat scans unless I fear that there is a progression or something is changing. And just, be aware that mycosis fungoides gets worse in the skin before it ever goes inside of the body. So unless it gets worse in the skin, there's really no big reason to test for to test the inside of the body, like to do a full body scan. I hope that answers.
Yep. And I do want to apologize. We're having some technical problems. That there's people messaging our IT person that they can't get in. So I don't know if they can hear us or if it's just a blank screen. But if you see me looking off screen, I'm trying to see if we can figure out what's going on and why other people can't join. So we'll go ahead and go to our next question, Mike. Is what are the latest research findings on treating cutaneous marginal zone lymphoma?
Okay, I can take this. So the most interesting research finding is that the cutaneous marginal zone lymphoma was kind of changed. The definition of the cutaneous marginal zone lymphoma was changed to a lymphoproliferative disorder, and this really makes you think how things are evolving a little bit, meaning that that we are understanding more and more that this lymphoma doesn't really go inside of the body, is not really a big threat for the patient's life. What we are doing here, which I think is very interesting and a little innovative, is we are doing a 2-gray radiation, which is a very low amount of radiation. And I really like that because the patients get their lesions out and they don't really get any side effects from that radiation. Other things that can be done are the Rituxan intralesionals injections. And that can be an option, and sometimes it works really well. And then ultimately, there's not big new drugs on the horizon, unless Dr. Geller has better news, because it really is it really is quite an indolent disease, and again, it's not called lymphoma anymore, but lymphoproliferative disorder. So I think that's very reassuring.
Yeah, so I totally agree. I mean, there is no big news in this field, specifically because it's becoming more evident that it is something that is more inflammatory and less neoplastic, less cancerous. We do try to treat it when it's on areas that are of big concern to the patients, like specifically cosmetic concern, like on the face or on the hands. But we have patients that have lesions or multiple lesions on the trunk, and if it's undercover and it's not too bothering to the patient, we can also monitor this lesion. We can use some topical steroids or intralesional steroids also that are helpful sometimes. So it's something that has changed in the last few years, the approach to this specific subtype.
Gave me a clue on what's happening, so I'm going to communicate in the lobby chat to see if it helps the rest join us. So are there new therapies in the pipeline?
For mycosis
For
fungoides?
anything to do with cutaneous lymphoma, we're always looking for, what is there anything that you know of, any clinical trials that either of you are participating in, anything that you can share that you hear about what's coming?
Well, I think
And if the
the
answer is
most
no, we know this is a tough disease, so don't feel like you have to come up with something.
I think the most exciting ideas and trials come really from the immunotherapy. We were initially pretty skeptical and a little scared in doing immunotherapy for these lymphomas because they're still T-cell lymphomas, right? And in some of the diffuse T-cell lymphoma, the systemic T-cell lymphomas, drugs that stimulate the immune system have sometimes produced hyperprogression of the disease, but it seems like in mycosis fungoides and CTCL, really this doesn't happen. And so we're running a couple of clinical trials. Some some of you may have tried this drug called mogamulizumab. That's already in the market, and we have it, and it's one of those drugs that really work with the immune system to train it to go against a lymphoma. And here, for example, we are combining it with another drug that stimulates the immune system in another way, in a slightly different way. So that's really exciting. Other medicines that we can use right now for mycosis fungoides and Sezary are the checkpoint inhibitors. Sure, this is not really the front line or not even the first 2 or 3 lines, but certainly it's an option for the patient that's becoming more interesting, as well as the bispecific antibodies that have been used a lot in the B-cell lymphomas. And now there are a couple that also can target cells like mycosis fungoides and Sezary. So that's one really, really new field or new way of treating the disease. And then there's also this LAG3 antibody that's new within the last 2 or 3 years. It's been there's a couple of reports showing very good results. So that's another drug that I think has potential. And then really we are doing clinical trials with all the drugs that we use for the peripheral T-cell lymphomas to see if they work as well in the cutaneous lymphomas. And sometimes it's really similar, like we see responses in both, and some of them are pills, which is really great. And whatever has a very low toxicity and very good results is what we are looking for. And for drugs that have a little bit more toxicity, like for example, the brentuximab, we are doing trials where we lower the dose at the minimum level. And that may help with the toxicity, but still preserve the response. Ultimately, this is all in trials, so we'll see the results pretty soon.
Yes, I can add to that we are trying, because we have, our toolbox is not, as full as in other, cancers, but we do have some good drugs that we can offer in different stages. And currently we are doing some trials that try, as Dr. Ghione said, to see how we better or optimize the way that we use these tools. So for example, for patients with more early stage disease, we have these trials that we give them full body radiation with the low doses, and then once we get clearance, rapid clearance of the skin, they can we combine that with bexarotene, with tolgretin, which gives us long remissions or long control over the disease. So doing these trials of using some of them are older or new, and some of them are newer approaches, but doing the combinations, this is another step in, trying to get to better treatment and better care for patients. So this is something that is not like new therapies, but it's like new approaches or new uses of the old methods and old medications that we know.
All right, thank you both so much. And whatever the information that the attendees gave me and how they get in, I've shared it in the chat, and we've had a few people join us. So sorry for the difficulty getting in. It's always nice when a system changes and we don't know how to use the changes because we didn't know they had the changes. So with that, we will go ahead and go to our next question. Is when a patient presents with a biopsy showing spongiosis and negative for diagnostic mycosis fungoides, what additional tests can be done for a confirmatory diagnosis? What additional labs can be done to negate saying it's just eczema, which is a frustration we hear quite a bit from our patients on being misdiagnosed for years. So what can the patient do?
Well, this is the story of many patients. Like they just have repeated biopsies, and then one ultimately shows mycosis fungoides, and you can start treating them as that. It's very hard because I think what you can do is, first of all, get a second opinion, which is, sending the biopsy to a different center, maybe a center where they see a lot of cutaneous lymphomas, where they can do another assessment of your biopsy. And then one other thing that the pathologists look a lot at is the clonality of the T-cell receptor. That can be useful as well to see if there's a clonal process of the T cells. But the majority of the times it's really hard, because even here we read the biopsy very often the same way that the local pathologist reads them, and we just end up doing another biopsy of a lesion that maybe looks a little bit more like MF and go from there. So, but most of the time we see a patient that has finally a diagnosis of mycosis fungoides after 4 or 5 biopsies. That's really frustrating, but that's kind of the norm.
I would add 2 things to that, and I completely agree with what have been said, but there is a possibility that still we're talking about eczema or psoriasis, and there is we still don't know exactly what, pushes forward these, atypical cells to become infiltrated in the skin and for mycosis fungoides to evolve. So in some cases, and some theories do talk about a chronic inflammation of the skin, like happens in long and chronic eczema or chronic psoriasis, and then out of this inflammation, one clone becomes prominent, and then it becomes a skin lymphoma. So it might be that, what was biopsies along the years, what this chronic inflammation, and eventually, as time goes by, we do another biopsy until we catch it after it did this transformation to the cutaneous lymphoma. So this is one thing that is important to understand. So it's not necessarily that all previous biopsies were wrong. It might be that this is simply the process that happens. I mean, most cases that have long-term eczema will not develop mycosis fungoides, and this is also interesting to understand what drives mycosis fungoides in certain patients, and in certain patients it doesn't. And that leads us to the most frustrating thing in mycosis fungoides, which is that we don't have one test that we can run on the patient and say he has it, the patient, he or she, or they don't have it. We still don't have something like that. We are trying to see if there are specific genetic alterations or genetic mutations, like in other hematological conditions. Some of them we have a typical mutation or a typical, marker in their blood that helps us to the diagnosis. But in mycosis fungoides, unfortunately, still we have many conditions that overlap with mycosis fungoides, both in clinical appearance, by the way the rash looks like, and also under the microscope. And I think that once we have something that is better diagnostically, a better diagnostic method to diagnose it, that will be like a big breakthrough in this field.
Great, thank you. That was really good explanation. It's one of the first times I've heard it described that way, with the diagnosis of the eczema or psoriasis ahead of time. It was very good. Thank you. So we had a follow-up question asking for a little bit of a clarification. When previously we were talking about inflammatory, not cancerous, because that apply to both mycosis fungoides and Sezary, or is it just to one or the other? And we're all trying to remember what that one was.
Lymphocytes are part of the immune system. And like I explained to my patients always, for all of us, we have lymphocytes in our skin. This is where they need to be, because this is the place where, the outside meets our body and our body needs to react to the outside threats. What makes, lymphoma is that we have more like lymphocytes than what should be. The lymphocytes are, placed in areas in the skin that are not supposed to be. And the lymphocytes are not normal lymphocytes. They're atypical ones. They can be large ones. They can be lymphocytes that lose some of their, the proteins they have on their membrane. Something is going wrong with these lymphocytes. But sometimes it's difficult to identify these lymphocytes, abnormal ones, because the immune system is trying to get rid of them, of the abnormal population. So you have a mixture of like abnormal cells and, reactive cells against these abnormal cells. So you end up with, a mixture that sometimes it's very difficult to, differentiate from one another. So this is what I was referring in, inflammation and cancerous process. So cancerous process is the cells are, numerous, they're in large amounts, but also they are in places that shouldn't be, mainly in the epidermis, the upper part of the skin, and their appearance is abnormal. And usually they are clonal, meaning that they all come from one mother cell. So this is what makes it different from inflammation, that you have many cells, but still they're in the right place. Still the cells are in normal shape, and they are polyclonal, meaning that they come from different clones. Different cells are, making that infiltration.
Yeah, I just wanted to clarify that before we were talking about the primary cutaneous marginal zone lymphoproliferative disorder, and probably you started listening from that point. We were not talking about mycosis fungoides when referring to, more inflammation like versus true lymphoma. But yeah, this explanation also fits for all kinds of lymphomas.
Thank you for the clarification. There's so many different subtypes, and everyone has its own little uniqueness that sometimes when we start talking about it, it can be difficult to follow along, especially if you're just freshly diagnosed, because there's a lot of new words. And speaking of new words, I am not even going to attempt on this one because I will butcher pronunciation. So, and this is new to me. So I don't know who would be the right one to address this question.
Certainly, Shamir.
I will take this, but you can just do, follow what the physicians do when the words are too complicated. They just use the acronym. So you can use PLC. PLC is easy to remember. But pityriasis lichenoid chronica, it's a condition that, like, we mentioned eczema before. This is like an inflammatory condition. It's a dermatological inflammatory condition that has some overlap with cutaneous lymphoma, specifically with the subtype that is called lymphomatoid papulosis. But PLC is more like psoriasis in its, pathological appearance. But many patients are, end up with something that is suggestive of cutaneous lymphoma versus pityriasis lichenoid chronica, because this condition is also like some of the CTCL, types. It appears like as a chronic rash that is made of red papules, and they come and go, and they are sometimes very itchy. And when you do the biopsy, you see that also you have a lot of lymphocytes there, and but the features are not features of lymphoma. the lymphocytes are normal appearing, they're just a large amount of them, and they also change the way that the epidermis is dividing. So you have an epidermis that is sometimes very thick, so it's more like a psoriasis rather than a mycosis fungoides or lymphomatoid papulosis. But this is one of the, if we go back to the other questions, this is one of the diagnoses that sometimes it's very hard to differentiate from cutaneous lymphoma. And we have many patients that come for, confirmation of their diagnosis after it was outside called by some PLC and by others mycosis fungoides, and we need to decide between the two because the treatments are quite different.
Can be to get the proper diagnosis. So thank you. An early stage FMF patient, our early stage FMS patients able to regrow their hair after treatment. We've actually seen quite a few of these lately, and I know some of the doctors had said, is it the treatment or is it just you're already predisposed or you're already losing your hair? So one of the kind of questions people ask is, if I'm losing my hair, does it mean it's effective or does it have nothing to do with it? So this one's more recently asked, but also always complicated to answer.
Yeah, I think it really depends from person to person. And so usually there's not just so for folliculotropic MF, there's not just really the loss of hair, there's also some lesions going together with that. And I guess to see if the mycosis fungoides goes away from that spot, you would look for the skin to going back to normal. And ultimately the fact that the hair comes back is kind of really goes person by person. Ultimately, another way to look is to do a biopsy if it seems like the MF might still be there and so not really responding to the treatment. But in general, I would say if the accompanying lesion resolves, the success of the treatment is not really related to the fact that the hair grows back, unfortunately.
Yes, I agree with that. I mean, I think that there are two main factors other than, the treatment and the response to the treatment. One is the chronicity of the process. If it's a very long process, chronic process of like MF that involving the hair follicles, so sometimes eventually the hair follicles just go through regression and then you don't have hair follicles even after you get rid of the MF, and the hair cannot grow because it's like a scar. And the other issue is how much inflammation or infection you have. Also, that can cause scarring. And then once you have a scar tissue instead of normal skin, even if you get rid of the MF, you end up with a scar tissue that cannot regrow the hair. So there is no one answer to that. It depends on the treatment, like Dr. Ghione said, but also on the fact on how inflamed, the areas are, how much, how long it's been going on.
So every patient is different. I think when I first started with the foundation, one of the first things one of the doctors said to me is, if you've seen one patient with cutaneous lymphoma, you've seen one patient, because everyone is so unique on that. So, all right, on our next question, will there ever be a time I won't have flare-ups? This one's kind of, yep.
So I think really the natural history of mycosis fungoides is to come back and start again. And I think if your personal history is that the MF flares up and you haven't found a treatment that can control it for a very long time without flare-ups, then that's kind of what is gonna happen. until maybe you try and you find that medicine that can last for a very long time and don't have side effects and just keep you without flare-ups. But that's kind of the goal of our treatment, right? Is to control your skin the best that we can and try to avoid the flare-ups. But ultimately, we can really get rid of the mycosis fungoides. So one of the frequent histories of the patients is that they ultimately get on a treatment. They maybe that maybe works very well for a very long time, and then at some point it kind of starts not working as well. And our goal is really to keep you on a safe medicine that doesn't have as much side effects for the longest time possible before the next flare-up comes, and even to try to prevent the flare-ups. But it's kind of like if your history is sort of like that, then until we find the medicine that really works for you, it's probably gonna be your story.
Okay, thank you. I do want to say we're down to our last 10 minutes. So if you have any questions, please get them into the Q&A and we will attempt to get to them in our final 10 minutes. After an intralesional injection, will the nodules return in primary cutaneous marginal zone B-cell lymphoma?
So the lesions can recur after injections. Usually what gets rid of it and it doesn't, won't come back is adding like radiation, local radiation, low dose, like we mentioned before. In the following radiation, usually we don't see recurrence at the same site. We can see new lesions appearing elsewhere. But after like injection of topical steroids, I got to see some lesions that regrow. Sometimes there still remains at the deeper parts of the dermis, and then it like proliferates again. While with local radiation, usually it just gets rid of the entire lesion.
Okay, thank you. Our next question is someone heard some information and wanted to see if you had any comments on it. Is that they had read there was a potential link to hydrochlorothiazide and CTCL. Is this something that should be avoided for patients or maybe even family members if it increases risk? So I guess the question first is, have you read anything or seen anything about this link?
I haven't. Have you read anything, Shamir?
No, me neither. I mean, there are some drag rashes that mimic mycosis fungoides and CTCL, and some of the water pills can cause drug eruptions, but truly or actual mycosis fungoides is not something that I'm aware that is associated with any diuretics. And also the question about the family members. So actually, that's also going like a bit backward. We don't have any evidence that mycosis fungoides is an inherited disease. And although there are some like anecdotal reports on family members who have have cutaneous lymphoma in the same family, we don't know that there is some like a predisposition within a family to develop mycosis fungoides, like a genetic one.
Okay, thank you. On our next question is, up to how many minutes can one be on UVB treatment? This particular patient is up to 8 minutes right now. And again, they're going to answer based on the patients that they've treated, not specifically on you, and you should discuss this with your physician.
So the way phototherapy works is that the time is not the main issue. The main issue is how much energy you get during the treatment, and the energy is multiplying the time with the emission of the UVB light from the bulbs inside of the photo booth. Meaning that if you get to a photo clinic and they've just changed the bulbs and it's new bulbs and they emit a lot of high doses of UV per minute, then you might get the same dose that you currently get during 8 minutes. You can get it in 2 or 3 minutes. And this is like a calibration that they're doing, like the technicians in the photo clinic. So the actual, many patients come to me and say, well, I got to 4 minutes or I got to 8 minutes. For me, it says nothing. I need to know how much, how many joules or millijoules they're receiving during the treatment. That is, the way that we follow the treatment.
Right, thank you. So I think this is going to be our last question for tonight. I'm developing some red-colored pimple-looking spots on my arms. Is it likely MF? They have MF on other flat patches and crinkly plaques, but they don't look pimply. So would you suggest, if this was your patient, getting a biopsy, or is it a known presentation of MF?
Yeah. Generally, we always want to biopsy something new in mycosis fungoides, especially if it's a new different lesion, etc. That said, some mycosis fungoides, it also depends on the history of the lesions, like how are they developing, and if they're going away by themselves, if they're evolving, if they're increasing in volume, and then going away. That might be something that's called inflammatory papulosis that can also be associated to mycosis fungoides, and it's not really a lymphoma, but it kind of looks like a lymphoma under the microscope. So we really need to biopsy it to figure out what it is. If it's if the pimples are something like folliculitis or they are a little inflamed, then it might just be it, like a local inflammation or infection. And so really, I think the goal here is whenever you see something different in your mycosis fungoides is to call your dermatologist and have a look if they can take a biopsy.
So I usually tell my patients, I mean, and we just, I think our discussion today highlighted that, it's very heterogeneous disease and it's very hard to diagnose and to treat. And, but on the other hand, I mean, still when you are diagnosed with cutaneous lymphoma or mycosis fungoides, you can still have like regular diseases, right? Regular skin diseases like acne, like folliculitis. So not necessarily everything that you get on your skin will eventually be cutaneous lymphoma. So I agree that you need to consult with a, with a dermatologist and see. Usually I recommend patients to see if the rash goes away on its own or with like regular treatment for more common conditions after treated, then it shouldn't be, further worked up. But if it's more than 3-4 weeks and it doesn't respond to the regular treatments, then we need to check it. I mean, we have the advantage and the disadvantage of treating the skin. So the skin is out there, so you see it all of the time. So you look at your disease, and the disease looks at you, and it's very easy to go into a lot of stress about your skin, and it's important to have a good physician who follows it, and you trust him, and then you can consult with him whenever something shows up. That's really important.
Thank you so much for that. So with that, we're going to wrap up. Dr. Geller, Dr. Ghione, thank you so much for taking the time out of your busy schedule to answer questions for us. And to the patients that are watching, thank you for joining us. I will be sending out an email with a link to the recording. And if you have any additional questions that come up, just please reply to that email and I'll see if we can address them. So thank you all again. I hope to see you at some future programs. And please don't forget to take the survey. Yes, I'm going to mention the survey again because we need to hear from you to make sure that we are fulfilling your needs. So thank you all again and have a great night.